Hello, everyone, and thank you for your attention. My name is Amy Pham. I'm a PGY1 at Northeastern Health System Internal Medicine Residency Program, presenting a medicine leadership approach to timely inpatient discharges. Background and introduction. Inpatient discharge is a complex transition that requires appropriate planning and coordination. From a systems perspective, discharging patients earlier in the day reduces interdepartmental strain and increases hospital throughput. From a patient-centered view, earlier discharge improves transportation options, reduces delays, helps patients feel more confident and prepared when they leave, and improves access to pharmacies for timely procurement of medications. However, delays in discharges remains a persistent issue nationwide. Research has shown over 1.2 million excess hospital bed days result annually from delayed discharges, costing the healthcare system over $100 million per year. Earlier discharges can also reduce emergency department crowding, lower patient mortality, decreases inpatient length of stay, and improve patient satisfaction. Our project's aim was to have at least 35% of patients discharged before noon each month by July 2025. We focused on identifying specific barriers, both systemic and individual, that prevent timely discharge, and implemented sustainable strategies to overcome them. Project design. We began by tracking discharge orders times across the inpatient service. Each resident received monthly feedback showing their personal performance, which helped foster accountability. A minimum number of 5 residents across all inpatient services were working on any given time. However, some months there would be an additional 1 or 2 residents who were also on an inpatient service, depending on scheduling. Our team implemented plan, do, study, act cycles to test various strategies and refine our approach over time. Strategies. We began discussing potential discharges at the end of each day so teams could prepare proactively. Discharge orders were pre-written when possible, allowing for early attending sign-off. Residents also notified attendings in the morning of patients ready for discharge, which helped expedite review. We collaborated with nursing leadership to streamline medication reconciliation, which was a known bottleneck. Additionally, we distributed visual reminders such as flyers seen in Figure 1 and posted them around resident and attending physician work areas to keep early discharge top of mind. Our residency program also facilitates didactic lectures, usually multiple mornings throughout the week between 7 and 8 a.m., which we identified as a possible constraint, but importantly, resident lecture schedules were not altered as preserving academic time was a core priority. Results and discussion. Our project was initiated in July of 2024 at the time of a new class of residents joining the program. Over the course of the first few months, the new intern class of residents were learning how to use our EMR, which we considered as a possible factor contributing to delayed discharges. After the first few months, we reevaluated our goals and determined that an initial goal of 50% discharges before noon was not realistic or feasible to achieve. Thus, our goal was readjusted to be 35%. Other published QI projects tackling the same issue reported similar goals anywhere between 30 to 40% and were used as a reference for our new goal. We noticed a decrease in our performance below our goal and brainstormed different interventions and strategies as previously mentioned, and we saw a meaningful increase in the number of discharges before noon following these changes. The strongest predictor of success was the number of residents on inpatient services. When more residents were available, morning discharges increased significantly. Conversely, months with fewer residents saw a decline. There was also variability based on attendings and residents' individual workflows, which suggests that standardization and team-based communication are key. Limitations. Delayed or incomplete discharge medication reconciliation remains a challenge, especially during busy shifts. At our facility, the home med rec is a requirement to initiate discharge orders, and completion usually falls under the responsibility of nursing staff on admission, which was occasionally difficult for us to control beyond requesting the nurses directly to complete them. Additionally, patients being discharged to nursing homes, rehabilitation centers, or long-term care facilities require extra interprofessional coordination that cannot always be expedited. Finally, care teams often have personalized workflows, making it difficult to apply a uniform strategy across all providers. Conclusions and next steps. In summary, increasing morning discharges improves both patient experience and hospital efficiency. Even when the discharge occurs afternoon, initiating the discharge workflow early leads to better outcomes. Next, we plan to improve cross-team coordination, especially between residents, nurses, and case management staff. On review of other published strategies involving the night shift team and identifying patients who might be ready for discharge the following day is also a strategy to consider. Our goal remains to implement sustainable change without compromising patient safety or resident education. Thank you for your attention.